Thank you, Bruce. Good afternoon. So today we'll talk about platelet-rich plasma and its use in muscle, tendon and ligament injury. Now, as Jeff alluded to, this is kind of a sexy topic in sports medicine at the moment. It probably has hit Australia later than the other continents. Certainly in my experience in Sydney, when I left 2 years ago, it was only really just starting to be used by mainstream sports medicine. However, remember that everything that is sexy is not always good. So we'll talk about, very briefly about platelet-rich plasma because most people know what it is. We'll talk about muscle, tendon and ligament injury and why it might work. Look at the basic science evidence, and then we'll look at the human research, of which there isn't a lot. I'll disclose my bias now. I'm a physician and a scientist, and I like evidence-based medicine. I understand it's not always easy to practice evidence-based medicine, but I think we should try, and emphasise try because it's not easy, as best we can. And then we'll look at, despite the evidence, what in practice we might be thinking of using PRP. So we know that PRP is the platelet-rich plasma. It's the plasma component of blood after centrifuging. It has numerous growth factors. Here, these are just a few listed, and look, to be honest, there's probably more in there than we know about, that we haven't discovered yet. So we know there's multiple growth factors. We don't yet know their exact role, their function even. The interactions are complex. There's obviously regulatory factors, both stimulatory and inhibitory. It's really hard to do good in vivo studies of function. And I guess the real question is, so will it work? Does it work? So when we've got isolated growth factors, we can study those. So not PRP, the actual single growth factors, and we can see what their effects are. This is a slide from Dr. Hamilton, and you know, it shows a lot of the evidence. But when you look at it, that's all we know about growth factors. So you can see there's a lot we don't know. If we look firstly at muscle injury and PRP use in that, we have to understand the healing and the phases of healing. And this is the one of most interest, the regenerative phase. That's when PRP is most likely to be effective. Now that's using logic on this. We can't prove that. And remember that, as I say more commonly these days, if medicine were logical, it would truly be easy. So if we actually look at what we have, we've got generally positive animal model studies for muscle injury and PRP. The difficulty is, even amongst a few studies, they're very heterogeneous. You know, we've got muscle contusion models, we've got muscle stretch model, we've got surgical muscle lesions. This is probably the most useful, and that's more or less what we should be doing when we get to the stage of doing human studies. Despite that, we get some good effects. We don't get a change in muscle function when we look at this, but we do get an increased recovery with PRP when used in animal models across these mixed groups. When we look at the human studies, there aren't a lot. Okay, we've got this study which was basically looking at traw meal and active vegan, so mixed together, compared with PRP. Again, a very heterogeneous group. We've got abdominal oblique muscle strains thrown in with rectus femoris, with adductors, in a mixed bag, use it for everything. Despite that, it did show that across the group, people returned to sport earlier. And they looked at MRIs to see whether there was regression in the edema and the bleeding, and there was when they looked at them. Probably just as importantly, no side effects in this study, and as in most studies, there are not side effects reported. This is a very famous presentation. It never made it to the publication stage. Not sure why, but a case series looking at skeletal muscle healing. And again, they showed decreased recovery time, importantly, no re-injury and no side effects. This is just a case study of a bodybuilder who had an adductor injury, PRP, was back bodybuilding at 1 week. So that's the evidence for muscle injury and PRP. Pretty comprehensive, eh? We know there's positive effects, okay, but what we don't have is good randomised control trials. I'm not saying it doesn't work. I'm saying I don't think we can really show that it works as yet. And as alluded to in many of the talks in many different areas, really we need good studies. We need randomised control trials to really have a good look and see whether it works. So basically my recommendations for use in muscle injury, you know, first it's important to know that there aren't a lot of side effects, and truly we haven't got big numbers in the studies, but from what we have there are no side effects, there are no recurrences. So in elite sports people, I don't think for your average punter, but for elite sports people with acute muscle injury, there may be a role to decrease sport rates. But remember, for now it's still restricted by WADA up until the first of next year. We definitely need good quality randomised control trials to really know all of these things. You know, what should we be using in the injection? Should we be using PRP? Should we be using whole blood? Should we be isolating growth factors from the PRP and trying those? And I think in time that will be probably what we do, but you're talking about many generations, I would think, before we're at that stage. The timing of the injection, no one really knows when to use it. Do you use it straight away? Do you use it at 5 days? Do you use it at 2 weeks? Do you do many injections in a series? And what do we do as adjunctive treatment as we're doing these injections? So like poor old Bart, we don't know quite what's good and bad just yet. That's bad. Okay, so I think that's South Africa, not Australia. Okay, so when we look at acute tendon injury, again, the healing phase is really the reparative, regenerative phase is what we're most interested in. And various growth factors work at various times throughout this phase. So, you know, should we be looking at these ones? Should we, you know, is this the stimulatory one for this? These are things we don't know. Just a quick slide of the different growth factors and how we think they work and the evidence for that. So, when we look at animal models for acute ligament injury, so let's look at medial collateral ligament of the knee first. There is some evidence that with platelet-derived growth factor, so a single growth factor, not PRP, that they're effective within 24 hours, and there's a plateau in the dose response. So the more you use doesn't necessarily make it better. With ACL, you've got early improvement with most of the biomechanical properties, but late there's no improvement. Much more interesting are the human studies. So firstly, no MCL studies at all. Disappointing in a way, it'd probably be an easy study to do. In fact, when I found that, I wrote it down to remind me to do it or get someone to do it later on. When we look at the different sorts of ACL studies, this is bone, patella bone, and there are two reasonably good studies. Good study size, randomised control trial, showing no effect in clinical or MRI appearance of the graft. Again, with this one, this is one I found recently actually, it's in Spanish out of South America, so I was taking someone's word for what it said, but more or less when they looked at the MRI, there was earlier graft ligamentization, so the patella tendon turning into a ligament. And fairly impressive on 6 months versus 1 year when you look at the MRI, but again, no clinical or functional data from that study. So when we look at now hamstring ACLs, again, some reasonably good studies, although they're pilot studies as you can see by the group numbers, and no clinical or functional differences in outcomes. So if we're thinking about acute ligament injury, really currently there's no evidence of clinical or functional improvement, but it's possible that the graft ligamentizes early, so maybe we can return to sport earlier. That's something we'll have to investigate. So for now, the surgeons and the physios are still in a job, as am I guess. Okay, acute tendon injury. So mainly we're talking about Achilles tendon here. It's the biggest model. These are the animal studies, and it seems to be doing the right things: increased collagen formation, increased stiffness, and biomechanical properties. When we look at the human studies, there's a little bit of conflicting evidence. None of these studies are very good quality. This is a six-person case-controlled study. It did show early range of movement, better range of movement. This one is a randomised control trial with 14 people per group, so slightly better study. No difference in a functional test, and this one actually, this functional score was actually worse down the track, and they postulated that possibly there's a detrimental effect. Now, of course, we don't know that, but this is what we need to do the studies for, to make sure it works and it doesn't do any harm. So for acute tendon injury, I think really the jury's still out. We don't know whether it's good or bad, and to harp on it, we need the randomised control trial. So when we look at chronic tendon injury, so tendinopathy, there really are no specific basic science studies on PRP growth factors in chronic tendon injury, but there's some suggestion that it may help with angiogenesis and collagen synthesis. This is interesting. In one study, seems to indicate that intrasynovial versus extrasynovial tendons, the effects of growth factors in those are different. So it's horses for courses, we can't treat all tendons the same. So looking at Achilles tendinopathy, this is probably the best study on PRP to date. It was using 4 mils of a depot versus saline. Okay, so interesting choice of control, but nonetheless didn't show any significant difference in outcome measures. You can see the PRP group improved their visa scale by 22 points roughly versus 20.5, so not much difference. And the question about was saline the right control, even if it did nothing, there's not a change. If it was harmful, well, there's still not a change, so there should have been. There was a non-significant difference in the PRP group, 70% return to sport versus 57. That wasn't significant, but they did note the trend. In this case series, not a great case series, but did show that improved the Visa A scores quite significantly at 18 months. When we look at now patellar tendinopathy, so again a case series, this was an interesting one. They used quality of life scores rather than necessarily accepted orthopedic outcome measures, but they did use the Tegner score. And you can see here it's a pretty mixed bag of who gets better and who doesn't, but if you want to look on the positive side, you've got 70% who really completely recovered or markedly improved. Then when we look at a randomised control trial on the same thing, there's no difference. So I don't want to be overly cynical, but I think the case is that better studies don't show results, the worst studies do show results. And that's fairly clear throughout most of the slides. Okay, so when we look at now elbow tendinopathy, so tennis elbow, this was quite a good study. PRP versus cortisone injection. Again, you can question the use of cortisone as the control, but it's an accepted treatment. They used a very strange statistical measure of successful outcomes, and they showed that there was a significant improvement in successful outcomes. But as in most research, you normally look at the mean of one group versus the mean of the other to look for your statistical difference, and they did not do that. So I'm not quite sure why. Again, being cynical, I'd probably suggest there wasn't a significant difference. This study looked at 15 PRP, 5 controls, did show a difference, 48 points, so I guess 5 out of 10 pain reduction on a VAS scale. This was a study both on medial and lateral, so they had a bit of a mixed bag in there as well. The control group was mainly lost to follow-up. However, they did mention that one of the control group was asymptomatic, so I think if you'd been able to look at the results, they wouldn't have been significant. This one is actually rotator cuff tear rather than tendinopathy, and it's the only study looking at surgical repair with the application of PRP, and fairly impressive reductions in pain, but is that just the result of the surgery, or is it the result of the PRP? Without a control group, that's hard to know. Okay, so again, my recommendations for Achilles and patellar tendinopathy, there's conflicting evidence, okay, but the only randomised control trials don't show an effect. When we look at elbow tendinopathy and shoulder rotator cuff tear, there are limited studies, but they do show some evidence of effect. I think this is really the statement to take home, certainly for me. I find it difficult to confidently recommend the use of PRP based on the current evidence. And as doctors, we should be trying a bit of science as well as our clinical. So, first, do harm. Good studies are essential to show that there's no side effects or recurrences, and most of the studies have showed very few side effects. There haven't been recurrences. Some people get a transient increase in pain after the PRP, but really there are very few side effects. However, we need evidence, and that means scientific proof. So we'll await some studies. We are doing a growth factor, a PRP and a hamstring study here at Aspetar. One of the authors that I quoted there, Robert DeVos, is also doing a hamstring and PRP study in Holland, I believe. So there are some trials going on, but again, you're probably looking at a year to 18 months unless they're currently underway. So this is my summary of it. So it's mine. This is me looking at evidence saying this is what I use. So that's level 5 evidence, I guess, my opinion. So with acute muscle in elite sports, I think it may have a role to decrease return to sport, to decrease return to sport rates. And I think that's why WADA initially banned it for muscle. Acute tendon injury, I think there's promise that maybe, with an Achilles tendon rupture using PRP in addition, it may work, but I think we need to prove that. Really, I guess this is a bit disappointing. There's no evidence that for ACL and MCL it has an adjunctive role. Maybe that ain't promising. Achilles and patella tendinopathy, there's conflicting evidence, but really there's the good studies show no effect, and shoulder and elbow, limited studies but some evidence of effect. And this hot off the press, I think this came last week or 2 weeks ago, that essentially they've taken off the ban list for 2011 due to lack of current evidence concerning the use of these methods for purpose of enhancement. What they did say was that they don't believe there's any potential performance enhancement beyond the potential therapeutic effects, or even the therapeutic effect is not proven, and that WADA will monitor this as research results come through. So I agree with WADA. Thank you.